Welcome, everyone, and thank you for joining the Kirby seminar series. My name is Francesca Di Giallonardo, and I'm a postdoc at IVPP running the molecular epi of HIV New South Wales program. First, I would like to begin by acknowledging the traditional custodians of the land we gathered today and pay my respects to the elders past and present. Today, we are gathering on the land of the Bidjigal people of the Eora Nation. And I extend that respect to all Aboriginal and Torres Strait Islander joining us today here in person or online. Just a quick housekeeping. So the format for the seminar, we start off with presentation, followed by a Q&A session of the presentation. If you're joining us online, you can ask the questions throughout by clicking on the Q&A icon at the bottom of the screen. And for the audience in the room, there are microphones available on either side. Okay. So today we have Billal Obeng presenting. He is a PhD student at IVPP. Billal joined us as a student in 2020, but like so many, wasn't able to come into Australia. He is from Ghana, and so he spent the first 2 years doing his PhD online, which was challenging, but we got through. He then came to Australia in January 2022 and has been here ever since. He has been willing enough to present today, even though he has his RPR on Friday. But, and he's aiming for to submit his thesis in at the end of March. Yeah. Thank you.
Thank you very much, Francesca and Tony, for giving me the opportunity to undertake my PhD program in this area of research. And thank you all for honoring this invitation. First of all, I would like to acknowledge the Bidjigal people of the Eora Nation and pay my respect to their elders, past, present, and emerging. My name is Billal. So, for this presentation, I will be giving a short background, and then I will go into the concept, the methods used, results, and conclusion for each of those aims, and then finalize that with some acknowledgements. So the HIV epidemic was first detected in the US by CDC in 1981. And then soon after, Australia also confirmed its first case in 1982 at the Royal Prince Alfred Hospital. And ever since, there has been numerous strategies targeting testing, treatment, and prevention. And I've put here in red boxes some of the key interventions that have been instituted by the Australian government and championed by community members. First of all, in 1985, there was the introduction of the antibody testing, and this actually led to increased number of testing, and even some of these were retrospective cases. So you see that there has been a spike from 1984, and around that time, you have the number of diagnoses somewhere around 2,000 cases annually. Okay, so basically you have this spike, and then after 1980s to somewhere in 1990, there was a decline in the number of annual diagnoses until 2000, where it became stable until now. Now, in 1988, there was this implementation of the needle syringe program, which was very key in limiting the transmission of HIV among persons injecting drug use. And of course, the AIDS Council of New South Wales did tremendously well in terms of the educational campaigns across the states. However, in the last 15 to 20 years, there has been an intense number of biomedical interventions, and these have been the production of highly active antiretroviral therapy, starting from zidovudin, which was made available to persons who were diagnosed. In 2015, ASHM also brought out the treatment guidelines stating the initiation of HIV treatment after, and this was based on the CD4 count, basically. And now as we speak, it is just about test and treat. So basically a lot of interventions have led to that. One key intervention is the initiation of pre-exposure prophylaxis in 2016. Actually, it was initiated in 2016 and scaled up in 2018. And this has really led to reduction in the number of new diagnoses. However, the UNAIDS has a metric to measure the progress towards the elimination of HIV transmission. And this has been set out in their UNAIDS 1990 targets. Now, this target is to measure the proportion of individuals who have been diagnosed or tested and diagnosed in the general population, which is the first target. And out of that, it measures the proportion of those who have been diagnosed and are on treatment, which is the second target. And finally, measures the proportion of those who are on treatment and are virally suppressed. So by 2020, Australia had achieved the UNAIDS 1990 targets, and this was a very good indicator for the progress towards the elimination of HIV transmission. In 2020, UNAIDS fast-tracked its targets to 95, 95, 95, and the aim was to achieve the same proportion, but this time increase proportion from 90 to 95 in order to end the HIV transmission by 2030. Clearly, we do see that the prevalence in the general population also improved. 0.24 in 2020 by the review, and then 0.14 in 2022. So clearly, Australia has done tremendously well compared to other global, other countries in the globe. Now, I have to just mention that if you look at the comparison, the bar chart, you clearly see that for the UNAIDS 1990 targets, as I earlier mentioned, everything was achieved. But then if you look at the 2022, which is 95, 95, 95, we still have some work to do around testing. And so you need more intervention, which will increase the testing numbers in New South Wales, or no, in Australia, basically. So clearly, two interventions that have been instituted to really improve this prevalence is pre-exposure prophylaxis, as I earlier mentioned, which is basically taking medications that limit the risk of HIV acquisition. And then treatment as prevention, where persons who have already been diagnosed are given treatment in order to reduce the viral load. And the idea is that once viral load is reduced to undetectable levels, it means that transmission will also be limited. And that's what normally we refer to as U is equal to U. But there are still challenges. Recently, Dr. Sky McGregor reported that there has been a slight increase in the number of new diagnoses from 553 in 2022 to 722 in 2023. And so this is also another concern. The other thing is that if you look at the declines, even though generally across the last decade, there has been about 33% decline, but if you look at the population-wise, you see that there has been some uneven decline. So for instance, with MSM, there has been about 60% decline in the last decade, 686 in 2013 to 273 in 2022. But compared to heterosexual transmission, clearly the decline is not as compared to MSM, and that's around 25%. And so there's still much to do in that population. Now, if you take the MSM and you want to look at the place of birth, okay, so you realize that the Australian-born MSM has a greater decline, somewhere around 64%, whilst in Asia-born MSM, the decline is not seen over there. So to be able to do this, we will need to look at other interventions. And one of these interventions have been molecular epidemiology. Across the globe, there are 2 nations that have instituted this as part of their routine surveillance. The CDC actually leads the effort in the US, and Canada has also begun this effort. So probably if this is implemented in Australia, Australia then becomes the 3rd nation to routinely use this process as part of their HIV prevention toolkit. So if you look at molecular epidemiology and if you look at the literature, there is a clear challenge. And the issue has to do with trying to infer a phylogeny or a phylogenetic tree to sort of study the transmission within a population. And literature has confirmed that to be able to do this effectively, you will need to use the data under study. So you try to estimate whatever threshold you are using in order to use the accepted threshold for your population under study. So you don't just pick something and then use it in your population. And that's basically why for this aim, I try to look at what threshold works best in terms of the population. So as a way of concept, phylogenetic tree is central to molecular epidemiology. And that basically you need to take sequences, it could be even genome, any other genome data, not only just HIV, and then try to infer a tree that seems to be the true evolutionary, even though we don't have a true evolutionary tree, but a tree that will sort of help you to be able to know what is happening in terms of relationship. And here I have just demonstrated that with about 5 different sequences, sequence 1 up to 5. Now, clearly, what we do see here is that at the tips are the sequences that have been studied, and the horizontal branches here indicates the amount of evolutionary changes that have occurred in between those sequences. So, for instance, if you look at sequence 2 and 4, they are more related compared to sequence 5. Okay, so the horizontal lines actually represent the evolutionary change that has occurred over time. And then we have the probability that these sequences will always stay together every time you do resampling. So these are what we refer to as bootstrapping. And bootstrapping indicates that, for instance, if you take sequence 5, 2, and 4, 95% of the time, sequence 2 and 4 would always be together. Okay, so this is also one way of trying to one way of implementing within the phylogenetic tree to estimate the probability that a sequence will always be related to each other. Now, there are several ways of defining a cluster, and it's not as if you can just use the phylogenetic tree to just define a cluster as 5, 2, and 4 as a cluster. There are so many things you need to consider. So even though I'm showing this as a defined cluster, you need to study the epidemiology and also know several factors that can influence this phylogeny in order to define a cluster. So there are several ways of inferring a phylogenetic tree, and one of them is the distance-based method. Now, the distance-based method is based on the fact that a particular sequence within an alignment is compared to the next sequence. So basically, you are using the sequence data to know the differences between the two, and that is so direct. Okay, and once you do that, this is what we refer to as the pairwise distance. So you are just comparing each sequence to every sequence within the alignment. And once you're able to do that, you can build a transmission network. And this is what they have employed in the HIV trace, which is the HIV transmission cluster engine. This is the method that is used by the CDC in order to determine transmission clusters within the population. It's faster, which is the advantage, but it's also not so accurate compared to other methods. So that is also another thing that you need to consider. The other method that you can use in phylogeny is the maximum likelihood algorithms. And this is relatively accurate compared to the distance-based method, in that here you are trying to look at every particular position within the alignment. So if you have about 100 nucleotides within the alignment, you are comparing each of them. And based on the maximum likelihood, you infer the tree. So basically, this is more accurate compared to the distance method. However, it takes a lot of time to infer this tree, because if you have more data, it means that it takes a very long time to do this process, and it might not be very favorable for public health purposes, especially if you want to do this. Even more advanced forms is the Bayesian method, which uses the Markov chain Monte Carlo method. And here you try to select the best tree by comparing previously selected with current trees. And for you to be able to get this, it means that you need to do several iterations of the run before you can achieve this. But the good thing about this is that you can infer the origins of the data. And so we saw that during the COVID-19, most of the studies were using the Bayesian analysis to see where transmission started and where it's going. Okay, so the approach is not standard. There's no standard approach. You have several methods you can use. For instance, if you look at Australia, 2 studies I have presented here. They were actually doing the same thing, but using different thresholds. Sachs-Davies used the maximum likelihood approach, but also set a genetic distance of 4.5. That means here, if we want to look at the genetic distance, it means that it's quite higher compared to other studies where they'll be using 0.5. So it gives some allowances in terms of the building of the clusters. And then also incorporated the bootstrap. So this study was using 2 measures in defining its cluster, the bootstrap and the genetic distance. Leonardo and others also use a similar approach, which is the maximum likelihood, but they included global sequences. So sequences that were not part of the population. And here they define their cluster by a node that has no global sequence, because then if there's a global sequence, it means that there is some issues related to that cluster. So people actually use outgroups. They use other data outside of their studied population to also define these clusters. And that is also accepted. Now, within the US, or even North America, several thresholds have been used. For instance, the lie use a very large genetic distance, up to about 8%. To study clusters. So that means probably based on the question and the study, they would want to include more sequence within the clusters and then probably use other things to exclude some of those clusters. The key thing I have to mention is that as you increase the genetic distance, what is happening is that you are including more chronic infections and sequences that are very distant to each other. And as you restrict the genetic distance, what you want to do is to actually detect recent infections. And so it depends on the population and the study. 2 studies here actually led to the implementation. So for Oster, which is a very popular study, actually led to the implementation of molecular epidemiology in the US. And Brenner also did a very fantastic study, which also led to the implementation of molecular epidemiology in Canada. So in my study, what I did was to retrieve sequence data. And this is done in a very restrictive manner. And we all know what happens, especially when people mention molecular epidemiology in terms of the ethics and all that. Now, in Australia, the system is very restrictive and very protected. And that's very good because what happens is that at the clinic level where notification data is taken, this is not made available to the other part of the clinic, which is the laboratories, which also sequence the data. But all these 2 separate data goes to Cheryl, which is the Center for Health Records Linkage, and they use a deterministic approach to sort of link the 2 data together. And when they do that, they provide what we call the person project number PPNs, and they give back all these things to the data custodians. And then the data custodians then send it to us. And so we don't know anything about it. All we do is to use that sequence data and all the de-identified data to run our analysis. So basically, there is nothing like patient identifiers in this sort of analysis. Now, once this sequence is retrieved, the idea is that we want to study the probe. In fact, there's a unique challenge here. In other jurisdictions like the US and Canada, where they sequence the PO region, it means that the PO is readily available from all these labs. Over here, there are 3 reference laboratories. The Royal Prince Alfred Hospital, the Westmead, and then St. Vincent. All of these reference laboratories are actually sequencing different parts of the genome. And so what we did was that we would have to take a full genome first, and then extract regions that are that are similar to the regions that are sequenced by these reference regions. So first of all, we took out the structural genes, which is the GAG, the PO, and the envelope. And then within the PO region, we extract these 3 laboratory reference regions. So at the end of the day, we have 7 regions to work with for each data set. The other thing is that because we know that the HIV evolved based on the subtype. So different subtypes evolve separately. So we wanted to also control for subtype. So what we did was that we took data set from subtype B. Unfortunately, we didn't have full genomes at the time of this study in Australia. So we had to resort to another data set that looks similar to Australia, which is the Swiss HIV cohort study. So our collaborators gave us data sets from there, and then we use it as our subtype B data set. For subtype C data set, we use sequences from South Africa to study. Unfortunately, we didn't have subtypes CRF01A, which is a recombinant form. The next predominant recombinant form in Australia, it could have been good to include such a data set. But again, we couldn't get full genomes for that. So basically, we use these two data sets for subtype B and C. And then we added global data set, which is very random. So you have data from data from China, US, different countries, just to make sure that we are getting the same results. But again, we don't expect actual transmission clusters in this data set. Now we did a maximum alignment using a fast Fourier transform in Genius, just to align the sequence data set as I've previously described. And then we use an IQ tree, which is a tool to infer a phylogenetic tree to build our phylogenetic tree. The key thing is that because we wanted to estimate the threshold, we needed to explore the tree space. And exploring the tree space simply means that we want to know that every cluster that has been detected in one particular region of our of the genome would be the same across the region. And the idea is that because these reference laboratories are sequencing different regions, it is so difficult for you to change and say that everyone should do the same. But the idea is that if they are doing separate sequencing, we will get the same results, irrespective of the region that is being sequenced. So that was the idea. And finally, we do a cluster analysis using cluster picker, which is also a tool to select clusters within our data set. At the end of the day, we expect that even though different regions within the HIV genome are different, the cluster must remain the same. That's what we expect. And this is one of the output from my analysis. So for instance, if you look at the red lines indicate that there was one cluster which had 3 sequences. So each line represents a sequence, and then it goes all the way. And then we have the brown one, which is 2 sequences, and then the green one. Where there are dotted lines means the sequence was not present in that cluster. Okay, so that's what we expect. The first analysis that we did was the tree certainty or the bipartition estimation. This is a very important estimation, and it was recently introduced in 2013. The first idea was that if you want to compare phylogenetic trees from different regions, because of the fact that different regions evolve separately, it is important to look at the nodes. Now, at the nodes, which connects the tips, because the bootstrap even though the bootstrap is very reliable, if you have a very large data set, sometimes it changes. And so you would want to go deeper into the tree, which we call the internodes. So the internodes are nodes that connect multiple nodes. So you are moving from the tip into the deeper part of the tree. And that's basically what we did here. We expect that if you compare about 7 different regions and you are looking at the clusters, if the nodes are the same across the 7 regions, it means that the tree certainty should be 1. That is 100%. That means they are similar. But again, if they are different, then it must be approaching 0, basically. So here, what we saw was that if you combine all the 7 trees as a reference tree, so we take the full genome, all the other subregions, and combine them as a reference tree, and then now take the full genome and compare it to the reference tree. Take the PRT, compare it to the reference tree, and see the similarity across 2. That's why we call it the bipartitions. And then we realized that for the regions from the pole, relatively had higher scores compared to the full genome. Probably this might be as a result of the contributory effect of the envelope, which is hypervariable. We know that the envelope region is hypervariable, and so probably the effect that it has on the full genome might also lead to that. The other reason might also be that as you go across the tree, some of the clusters will be breaking apart. So like I showed in one of the pictures, you saw that some of the sequence clusters actually form and then break as well. So if you want to compare the clusters, you may not have it equally. And this might also lead to the reduced number that we see here. But the key thing is that if you look at the pore region and then the regions within the pore, which is the PRRT integrase and the RT integrase, relatively, they have higher scores compared to the envelope and then the guard. And it is not surprising because the envelope and the guard undergo intense selective pressure. So if you want a region that is a bit, you have some sort of consensus, it will be appropriate for you to use these regions from the pore. The other importance of using the pore region is that now that antiretroviral therapy are now available for the integrase like dolutegravir, it is important that if you sequence this region, you can always map mutations within the integrase region and see what is happening within the population in terms of the integrase. So it's always good to use that. And I know part of the MRFF project is looking at how best we can get the full genomes to use in molecular epidemiology, which Beth is working on. But again, before that, we can still use the pore region to do this. So basically, the availability and the comparability of the pore, which includes the diagnostic genotyping regions, the RT integrase, and the PRT integrase, is an important step. And that's just because, like I said, now that there are new medications which are targeting the integrase, we can use that to survey new drug resistance mutation within this region. Now, we then did the cluster mapping, which I've already shown, but clearly I have highlighted a typical case beneath that. And if we look at that case below that, you see that the pore region, all the clusters in red actually were identified as sequences in cluster. But if we move into the full genome, one of those sequences have been excluded from that cluster. And even if you go into the envelope region, 2 of the sequences have also been excluded out of the cluster. So if you look at this across the region, you realize that indeed not every sequence is added to a cluster. And this probably might have led to the low TCA scores that I showed earlier on. A similar thing was also observed for the global data, but again, as I said, the global data, we don't expect transmission cluster, but we just wanted to know whether the same event will be seen for that as well. But one important thing is the Swiss HIV cohort study, which is more like homogeneous in terms of their epidemiology. And clearly, you do see that the clusters were maintained across all the genomic regions, except the envelope, where 2 of the clusters were lost. So basically, the envelope is longer. It has a lot of information to compare it, but again, it is hyper variable for it to be used for cluster analysis. What we were also interested in is the number of clusters that were to be determined across each of these regions, and also the number of sequences within each of those clusters. Now, if you look at the Swiss HIV cohort study database, even though we did not have a very distinct point where we had the number of clusters and the percentage of sequencing clusters to be very stable, what we do see is that around 2.0 to about 4.0, you do see some sort of linearity around that. And so it's very difficult to be seen, but again, that's what we expect. As you increase the genetic distance, there will be more sequences added to the cluster. But if you have a case where you have, for instance, the pore region, where you see that there is some sort of linearity between 2.0 and 3.5, it means that this region or this threshold can be used to study transmission clusters. And this was even seen when we looked at the subtype C data set, where the entire region between 1.5 to 3.0 was sort of very stable. And so we agreed that if you look at the threshold of 2.0 to 3.0, you can use this for transmission cluster analysis, and it should be okay. Like I said earlier, if you restrict the genetic distance, what you are doing is that you are losing a lot of cases. There's a possibility that you are losing a lot. And that might not be very good for public health, because what you want to do is that you want to include more data sets in your clusters and then use other methods like contact tracing to exclude some of them. Now, there has been studies that have shown that bootstrap, which even though is very important, bootstraps above 70% will produce the same results. And that's what we saw in our data set, that even though we changed it from 70 to 90 to 99, the same results was seen, irrespective of the changes. So in conclusion for this part, threshold sensitivity analysis is very important in terms of looking at cluster analysis for a particular study. And it is important that you do this anytime you are going to work on a data set. Now, we also saw that the pole region is sufficient for accurate cluster analysis, and this is in conformity with past studies. So we know that most of this region sequence for drug resistance study is within the pole region. And so even if you don't have the full genome, you can still do some cluster analysis that will still produce accurate results. Cluster stability will also differ according to the subtype under study. Unfortunately, we didn't have CRF01AE, which is the next predominant subtype for Australia. And we chose 2.5 plus or minus 0.5 for our cluster analysis. And this was what we used for our next aim for detecting actual transmission clusters within New South Wales. So it is important to assess thresholds prior to implementing molecular epidemiology for a specific population and setting. Depending on the research questions, you choose your appropriate thresholds. For the third aim, we sought to quantify the effect of pre-exposure prophylaxis on transmission cluster dynamics for New South Wales. In fact, this is also very, very important, especially when PrEP has been scaled up. So you want to use cluster analysis to sort of inform public health and direct public health in terms of these interventions. As a background, PrEP is very effective as a prevention tool, and the CDC, the US Preventive Service Task Force, has noted that it reduces the risk of HIV infection by 99%. PrEP can be given based on, demand or even daily oral PrEP, and this is what we know here, the daily oral PrEP, where tenofovir disoprozil, fumarate, TDF, and emtricitabine is used, what we call the Truvada. Okay, so this is given 1 pill a day. Recently, the TDF we have another type, which is the tenofovir alafenamide fumarate. But the selection of this is based on clinical evidence. So the clinician would want to look at other factors, other clinical factors to be able to prescribe which one is the best. There has been studies that has shown that the TAF has higher intracellular levels compared to serum levels. And so it tends to protect against kidney and other bone infections. So it depends on all that. Now, these drugs are all NRTIs. They are all nucleotide reverse transcriptase inhibitors. And I say this because if you want to study mutation, it is important for you to track what is happening in the case of people taking PrEP. Okay, so if you are seeing any mutation that are around this area, then it means that there should be concerns in terms of changing the medications. Then we have other on-demand PrEP, which you need to take 2 pills at least 2 hours before sex, and then take 1 pill after 24 hours, and so on and so forth. Recently, there has been new generations of PrEP, and these have been found to be very effective. Even though they are not available in clinical setting, they are available for studies, and one of them is the cabotegravir, which is an integrase strand transfer inhibitor, which is normally given 2 months, every 2 months. But of course, the first 2 doses are given 4 weeks apart, and then subsequently you give it 2 months. Lenacapavir is really a game changer in terms of looking at the Purpose 1 trial, which showed that about 2,134 individuals in that study were all negative at the end of the trial. So it gives some sort of hope towards the elimination of HIV transmission. And this is very, very important. And this is normally given twice yearly injection. Even more important is that we know that adherence is a key risk factor for developing drug-resistant transmission. So if you have a medication that is taken twice yearly instead of daily, it means that adherence will be improved and sustenance on that medication will also be improved. So that is a very important aspect in terms of PrEP. So for this, the study concept was to obtain viral sequences and the epidata as I've already described, and then we use this to infer a phylogeny and then use that to detect transmission networks and then inform policy interventions. Here, similarly, we retrieve sequence data, and these were protease and reverse transcriptase sequences, and then we added integrase sequence, but these were very few. And then did multiple sequence alignment, cluster analysis as previously described, but here we chose 3.0, which was determined in our previous aim. So we use that as our threshold for the analysis. One key thing that we did in this aim was to use the Bayesian analysis to determine the impact of intervention on transmission rates. And that is very, very important because you want to see whether transmission is reducing or increasing within the population. And you can only do this when you employ the Bayesian analysis on that. As a way of demographics, majority of the individuals were males, and they were men who have sex with men. And most of these, the good thing is that most of these individuals were diagnosed at the early stage of the infection. So they had a CD4 count of 500 cells per microliters and above. And most of them had reported that they likely acquired the infection within Australia. And most of them were in the Sydney gay postcode area. And the Sydney gay postcode areas are areas that have males who identify as men who have sex with men or gay, about 5%. So all these individuals are within this gay postcode. And this is also one way of trying to limit improve ethical concerns, because then you don't want the reporting of residents and all that coming in. So you just put all of that into that. Again, we also have some appreciable number of persons within the Greater Western Sydney. So you have some cases within Greater Western Sydney and other Sydney areas. Generally, most of the infections were subtype B infections, and this is in conformity with other first-class countries like the US and Canada. And we have some amount of CRF01A infections, and this also confirms the kind of shift in terms of the population under study. So you have a lot of Asians or a lot of migrants coming into Australia, and this CRF01A is mostly found within the Asian population. What we wanted to do is that because we knew that interventions have impact on transmission and notification, we wanted to slice our data set from 2011 to 2023 into specific bins. So what we did was that we wanted to put one bin as 2011-2016, where there was no PrEP. And of course, you can say that at this time, there were also no COVID-19 pandemic. So you can say that this was free of any interventions or external interventions. Within 2017-2019 was when we introduced PrEP. So you can say that within this region, you have PrEP intervention. And then 2020, PrEP had already been implemented. It was in the system. But again, we had another extrinsic factor, which is the COVID-19 pandemic. So we also have some influence on that. And then in 2023, even though we don't have much data set here, this period is free of, you can say free of COVID, but again, PrEP is also available within this period. Now, what we see here is that, of course, subtype B declined from 2011-2016, which is the first bin, onto 2023. And then you see that there's a slight rise in the number of notifications or prevalence within the CRF01A region. So it tells you that there has been a shift in the in this HIV infection, and this this warrants some sort of intervention in terms of looking at migrant populations. Now, for PrEP-related resistance mutation, I call it PrEP-related resistant mutation because then, remember, all these individuals were persons taking PrEP, and probably most of these mutations that we saw may probably be as a result of what we call the breakthrough infections. Breakthrough infections are infections that have been acquired as a result of acquiring a resistant mutant. Or probably because HIV evolved faster, these people might have gotten the mutation not as a result of infection with a resistant strain. But this cannot be separated from each other because it's very difficult to do such analysis. Now, within the NRTI, we saw that one of the major mutations related to people taking PrEP is M184V. And M184V, even though it's very important, there is some favorable effect with M184V. And the reason is that even though it reduces the susceptibility to lamivudine and emtricitabine, which are very key antiretroviral medication, what happens is that it increases the susceptibility to tenofovir, and tenofovir is part of the PrEP. So if you see this sort of mutation, even though it is a mutation that reduces susceptibility to some of the drugs, the key thing is that for PrEP-related mutation, this is a very important mutation, and that is why. But one other mutation that we didn't see about 1% frequency was the K65R mutation, which is also very important within that, but I'll talk about it just in a moment. Now, I need to highlight that S68 gene is an accessory mutation, and it's quite worrying that we see it higher in this population. Even though in itself, it does not cause any effect, when it is in combination with K65R, this is really, really a big problem. In that K65R, we know that does not affect the susceptibility effect, but what it does is that it reduces the viral replication fit of the virus. So the viral replication is reduced, but in the presence of S68, the loss in viral replication fitness is replaced. So if you have an individual who harbors these two mutation, it means that you need to change the medication, especially when you diagnose the person. Okay. Now, the other mutation that I would like to talk about is the NNRTI, and I just separate them from the NRTI because the PrEP drugs are not related to any of this. So it means that if you are seeing these mutations within our population, it means that probably they would have been infected with a drug-resistant variant within this population. But as I said earlier, it might also be that they might have had acute HIV infection, which was not detected. And so probably there would have been some sort of mutation that has occurred independent of the drug. Now, one important thing I have to also mention is that there was only one individual who had an integrase strand transfer inhibition. And I only highlight this because there are new medication that targets the integrase. And so if you have an individual with this mutation, you need to also raise concern. The key thing here is that this person was not in a cluster and was diagnosed in 2021. But also had quite an appreciable CD4 count. So the person was not in the advanced stage. But this person was an overseas-born MSM. So it also warrants, like I said earlier, some of the interventions that targets migrants. So for instance, if it comes to testing or availability of treatment for migrants, it would also have to be considered. Then comes the estimation of the cluster growth. So what we did was that we inferred the phylogenetic tree and then tried to use the epi data map it. And this is very, very important because then you can see clearly where transmission is happening, which gender that transmission is happening most. You can do so many things. Once you have the epi data, you can always map it back onto the phylogenetic tree and you can see clearly where things are happening. Clearly, we do see that most of our persons were within. So most of the individuals we determined were singleton, so they were not part of any cluster at all, which is a very good thing. But very few of them were in large clusters. And here, large cluster simply means that we had individuals or clusters that had individuals of more than 10. So if you have individuals of more than 10, we put them as large clusters. And there were only about 7% of them, whilst the singletons were almost half of it. So this is a very good thing. And then we wanted to study what is happening within those large clusters. So we take the 7% and then we analyze them further to see what is happening. First, we wanted to use the same bins. So 2011, 2016, 2017, 19, 2020, 2022, and 2023. And then we estimated the reproductive numbers. The reproductive numbers are the estimates of secondary infections that are produced from a primary infection. You would expect that epidemiologically it must be 1, so that one person infects 1, so 1 to 1. And if it goes beyond 1, it means that transmission is increasing and there should be a lot of interventions coming in. And if it is less than 1, it means that transmission is declining. And so it's a very good measure of transmission within populations. Now, what we see here is that in 2016, even before PrEP, the RO, which is the reproductive numbers, was very low. But this increased within 2017 and 2019. There might be several factors, but again, one of them probably could be as a result of risk compensation. And when I say risk compensation, whenever interventions are available, people might feel reluctant to engage in certain protective. And in fact, Holt et al. In Victoria had reported this in 2018, how people were engaged in condomless anal sex. So sometimes intervention can also lead to some risk compensation, and this could probably lead to what we saw that. And again, in 2020, 2022, this reduced further. But again, this one too, I may probably say that it's as a result of the COVID-19 lockdown. So testing went down, sequencing went down. So we have very few data sets that you are using in this analysis. And of course, 2023, you need to interpret that with caution because we didn't have a very full data set to analyze that. So again, we just have to continue this sort of analysis over time. And then we wanted to look at each of those large clusters, each of those 16 large clusters, and see. Clearly, most of them were just around one RO of 1, which is a good thing. So, I mean, there's not so much going on within those clusters. But I will highlight 5 of them, which was just above 2 or just around 2, which means that 1 primary infection was causing 2 secondary infections, which is a concern. The first I would like to talk about is cluster 122, and I call it cluster 122 just because the software arbitrarily named it as cluster 122, so it's not any. Now here we had 10 individuals within the clusters, and the RO was about 2.4, so clearly they were producing more than 2 secondary infections, and this was predominantly subtype B infection. So they were every individual there was infected with subtype B. Now, on top of this, the top right corner, I show how these clusters were formed from the first year to the last point in the phylogenetic tree. So, for instance, in this cluster in 2012, there was only 1 individual, and there was no detection in 2013 up to 2015. And then in 2016, there were 4 new additions to this cluster. And this continued in 2017, where there were new infections added to this cluster. And in 2018, 1 more addition was added, and nothing was detected until 2013. So it looks like this cluster has actually stopped growing after 2018, after the implementation of PrEP. If we look into it even in detail, you realize that six of them were MSM, Australian-born MSM, and 4 were overseas-born MSM. 60% of them were in the gay postcode area. And the good thing is that half of them were detected at the early stage of the infection. Clearly, this shows that interventions must also look at the migrant population. So even though the epidemic is more of subtype B and it is mostly in Australian-born MSM, interventions must also focus on overseas-born MSMs. The other thing is about the residents. And even though we have most of these in our gay postcodes, but there are other areas that you are seeing there. So it tells you that if this cluster has 6 and 4 of them coming from other areas, it means that there's some sort of transmission occurring across residents. So we need to also expand that from that. And I know in the IAS last time, Professor Andrew Grulich mentioned that HIV transmission was nearly nearly come to an end within the inner Sydney area. And so going beyond that, whatever intervention is being instituted within the inner Sydney area must also be replicated outside of that. If you look at the next cluster, basically this was a bit higher, so 19 individuals, and then predominantly subtype B. But this cluster sought to be sustained from the first point, which is 2011, up to 2019 within the PrEP intervention. Again, it stopped growing after PrEP implementation. So again, probably PrEP implementation would have also contributed to the limitation of HIV transmission. Here, predominantly were MSM, and they were most of them were Australian-born MSM. And if you look at this, we have 37% of the individuals within the Greater Western Sydney, and again, most of them were detected at the early stage of the infection. For the next cluster, which was 20 of them, the RO was also above 2. And this was also predominantly subtype B infection. One key thing about this cluster was that nothing was detected at the start of the study, which is 2011. And the cluster was detected immediately at the implementation of PrEP, so in 2019, and has been sustained until now. So yes, cluster can be detected before that and after that. So it's, yes, we are doing very well in terms of the notification data. It's still, we need to put in more efforts in order to reduce it further. Of course, this is also similar to the previous one. You have majority of them, 70% of them in the Greater Western Sydney area, and most of them were Australian-born MSM. The next cluster here also was the first case was detected within PrEP implementation and has also been sustained. In fact, this is the largest cluster in the cohort. So you have it sustained across the period until now. And this looks a bit worrying. So probably you can inform public health with this, and then of course you can institute some of these interventions. The last cluster is of also great concern, and this is because even though the first case was detected in 2016 and has gone up to 2021, what happens is that majority of them were Australian-born, and of course most of them were in the early stage of the infection. But one key thing is that this cluster was predominantly CRF01A. So unlike all the large clusters which was subtype B, this cluster was predominantly CRF01A, and they were predominantly overseas-born MSM. So that is the reason for also focusing on some of these immigration policies in terms of testing and treatment. So in conclusion, majority of the identified clusters were predominantly Australian-born MSM with subtype B infection who were diagnosed at the early stage of the infection, which is a good thing. There were also low frequencies of DRMs to PrEP-associated NRT, and that's also a very good thing because then you don't want mutations that will limit the treatment options for these individuals. Now, large clusters had detected around RO of greater than 1, indicating that there were some increased transmission within these clusters. Now, the reduced RO that we saw in 2020, 2022, and subsequent increase in 2020 must be interpreted with caution because of the numbers, the testing, the lockdown, and so on and so forth. And together with this already existing intervention, like contact tracing and all the others, it is important that we probably look at the possibility of instituting molecular epidemiology to help detect transmission clusters in real time before they begin to spread. Lastly, I would like to acknowledge my supervisors. I know Francesca, at the time when I was back in Ghana, we had to do a lot of theoretical aspects of the project and to understand the concepts underlying molecular epidemiology, which actually was very, very instrumental, because then I needed this information shifting from being a laboratory-based person to more like a bioinformatic evolutionary person. I needed to know most of these concepts. And Tony has been very instrumental. I mean, accepting me into this program and then giving me a lot of information around drug resistance and all that, the clinical aspect of it, I think has been tremendous. And I would like to thank them very much. My family, even though I left them, and then my newborn, to my family to take care of them whilst I was away. I hope that hopefully I will go and meet them in good shape and they will not miss me too much. And thanks for UNSW funding my tuition and then the stipend and all that. Ansari has been very instrumental in terms of managing the database, requesting, and I used to worry him getting the data and all that. So, I mean, he has been very, very instrumental to this project. And we had our collaborators at ETH Zurich who advised us on most of the evolutionary models that we use for our study. They have been very instrumental. And then, of course, I will not forget the project partners, the Ministry of Health, St. Vincent, Westmead, Royal Prince Alfred. And very, very, very important is the Positive Light New South Wales and Icon Sydney. They gave us, in fact, some of them, I met them at conferences. They gave me a lot of, and Philip is here. Thank you so much. And I know he writes to me and I write to them and he gives me all the things that I'm supposed to know. And of course, ACTAP team, where I work with the Global Health Program, the Asian Health Pacific Health Program, Angela and then Janet, who are leading the team. I thank you so much. And all to the staff and then students of IVPP. Thank you so much.
Thank you, Billal. I think we have time for a couple of questions. Anyone in the room? Otherwise, I'll need questions from Jonathan. For the cases with INSTI resistance, did you have likely place of acquisition recorded?
So there was only one case, as I reported. And yes, so this person was in the Greater Western Sydney. So just one person, not in cluster.
We do have a place of acquisition. It's just not, we can give it to you if you're interested. Is there any more questions? No, no, I'll go. Okay. Thank you so much, everyone.